1 in 5 Brits have obstructive sleep apnea. Up to 85% remain undiagnosed and untreated.
Simple awareness of the significant morbidity and potential mortality associated with untreated sleep disorders. A slim Asian patient with unfavorable craniofacial features, although they're not obese, could still be at risk of developing obstructive sleep apnea.
When you imagine the future of sleep in a decade from now, what do you hope will be true that is absolutely not true today?
That's a very good question.
Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same. Hello and welcome back.
Yeah.
We are having a session of Sleep is My Waking Passion, and we are in London today. Although the UK has one of the world's most advanced healthcare systems, current estimates suggest that roughly 1 in 5 Brits have obstructive sleep apnea. Up to 85% remain undiagnosed and untreated. And in some areas, patients can wait over a year to get an assessment. This raises a big question. What does it really look like to navigate sleep care as an adult in the UK today? And how do new options like hypoglossal nerve stimulation and stronger ear, nose, throat, ENT, and sleep medicine collaboration actually change that story? Today, we're on the road for the very first time, and my guest is Dr. Chin Taw Cheong. I didn't butcher it too bad,
That's
right?
perfect,
Yes.
Alison.
Okay. He happens to be an ENT surgeon in the NHS who has become one of the most recognizable voices in the UK when it comes to obstructive sleep apnea, upper airway surgery, and sleep health. He's not only in the operating theater, he's also on TV, radio, social media, and he is talking about everything from snoring and OSA to the wider impact of sleep on health. He's also a very vocal advocate for the Asian community and personalizing sleep treatment in the UK healthcare system. And if you're new here, please make sure that you like, follow, rate, and comment. Share this episode with someone who you know needs to hear it. It also helps more people find these conversations, and it tells us that I should be doing this more often. I should be taking Sleep is My Waking Passion on the road. Thank you so much for joining me today, Ryan.
It's a pleasure to be here, Alison. Thank you so much for the kind introduction. But no, thank you to you as well for all your energy and passion into this space, raising awareness for sleep health in general and for all the incredible work that you do in the States.
Thank you so much. This is a Sunday, guys, by the way, and we were just chatting about the fact that I'm pretty jet lagged. I literally just got off a plane and then hauled butt to get over here, but we made it, and it's a real podcast studio. So thank you to Podcast Room here in Hanover Square for lending us this space. So I wanted to get into it a bit about, most of my audience is going to be kind of United States based.
Sure.
Though YouTube available in many languages all over the world, I'm really curious to understand a little bit more about how the UK system is in terms of how do you recognize, diagnose, treat sleep apnea? What is the usual algorithm? And where does ENT fall into that algorithm?
Well, thank you, Alison. So you're absolutely right to highlight that a lot of sleep apnea is still currently undiagnosed within the UK health service. Up to potentially 85% of cases remain undiagnosed. But generally speaking, the way that the British healthcare system is set up, you have general practitioners in primary care who are essentially the gatekeepers within the community that are the first point of contact for a lot of these patients when they start experiencing symptoms of sleep disorders like snoring, daytime sleepiness. So that will be the first point of contact within the primary care setting. So their first encounter would be with a general practitioner who would then refer the patient on to secondary practice. So that's a secondary care hospital or tertiary care hospital in some instances, like where I work at University College London hospitals. From then on, as you've rightly highlighted, the waiting times can take sometimes up to a year potentially. And once they reach the secondary health setting, then depending on the setup of the local sort of commissioning bodies, they could either be with a respiratory physician or an ENT sleep surgeon like myself. And then from then on, we'll be able to initiate diagnostics like home sleep studies, ambulatory sleep studies, of which comprise about 80 to 90% of the diagnostic tests that we do, and if required, inpatient level 1 polysomnograms as well. But it really depends on the local setup. Within London, our patients are quite fortunate that we have quite a mature sleep ecosystem and infrastructure, particularly within North Central London, where University College London hospitals cover. So they should be able to access the full spectrum of sleep diagnostics and sleep interventions as required. And they get referred into what is known as a wider sleep MDT, where we have collaboration, as you've mentioned, with sleep physicians, respiratory physiologists, or pulmonologists in the States. And the way that ENT sleep surgeons fit within that team in two ways, essentially. One is we are able to perform sort of an anatomical evaluation right from the beginning for any sleep disordered breathing patients that get referred, so that we can identify if there's any anatomical risk factors to be addressed early on in the pathway. And this has been shown to improve the compliance of things like CPAP therapy or customized mandibular advancement devices. So that's one sort of element of our role. And the second is to help patients who can't tolerate those first-line medical interventions and to consider potential surgical alternatives in the non-compliant patient.
Well, you were mentioning to me as we're kind of getting started that your involvement for your particular hospital in terms of where things fall in ENT is a little bit unusual.
Correct.
Can you kind of share a little bit more with the audience about that?
Of course. So within University College London hospitals, the majority of sleep referrals and sleep diagnostics actually sit within ENT. So we recently had a governance meeting about three weeks ago that showed that 75% of all sleep apnea referrals actually come through ENT, and about 75 to 80% of all sleep diagnostics within the healthcare trust sit within ENT as well. Potentially one of the reasons for that is that we have quite a strong legacy of treating patients with snoring and obstructive sleep apnea. So the drug-induced sleep endoscopy, which is quite familiar with a lot of sort of respiratory pulmonologists in the States and ENT surgeons, the drug-induced sleep endoscopy was actually first pioneered at the Royal National ENT Hospital, where I currently work in 1991. So we've been doing this type of work for a long while now. So the roots of looking after these patients, the commissioning pathways are quite mature within North Central London. But we have an extremely good relationship with our respiratory colleagues, our sleep medicine physicians, and we work together as a close multidisciplinary team to look after the more complex patients, and we frequently bounce ideas amongst each other to help, further care for our patients.
Getting back to something that you originally said, which is so much sleep apnea is going undiagnosed, and then the first care pathway being what we would refer to in the United States as internal medicine or the general practitioner seeing that adult patient. Where do you think the barrier is to recognition, or do you think that's an issue? Because that's one of the focuses of the American Academy of Sleep Medicine, is to highlight the importance of even adding a couple simple questions, trying to use a questionnaire like the Stop Bang or other tools that we have,
Yes.
And kind of embedding it in the EMR so that it is flagged. And then also getting the word out for our patients to say, listen, if you say these things, this should elevate the interest of your physician that something may be going on in terms of your airway and the possibility of obstructive sleep apnea. Is that an issue? Because it is in the United States, and we are working, I think definitely it's more recognized than it used to be. So what we are doing, the messaging, the fact that we're having this conversation is working. What is the status here in the UK?
It mirrors what's happening in the States very closely. So part of the sort of limitation in terms of patients seeking help is just simple awareness of the significant morbidity and potential mortality associated with untreated sleep disorders like sleep apnea. And raising awareness just through mainstream media or through social media or different platforms like what we're doing today is really potentially one of the first few steps to raise awareness, not just amongst the public, but also amongst physicians themselves, amongst primary care providers to highlight that sleep disorders are potentially a life-limiting condition that they might want to take pretty seriously. And things like the Stop Bang questionnaire are some of the sort of questionnaire tools that our general practitioners do incorporate in their practice. But the main limitation is trying to raise more awareness of the importance of screening for these types of sleep disorders in their patient population.
And one of the things I love to encourage primary carers to do, if you're listening, is to even something as simple as the Epworth score, or do you have an issue with snoring? It doesn't have to be complicated. And a lot of the stuff can be done when the patient's in the waiting room, waiting for their visit, for example. And then it kind of flags, especially if you know that your patients have these comorbidities that we often see associated with obstructive sleep apnea, right? Our high blood pressure patients, or diabetics, for example, are patients who have known cardiopulmonary disease or cerebrovascular disease. So I wanted to get to a little bit more about what's going on that you think. Let me rephrase that. So at your particular hospital,
Sure.
with the ENT heavy focus, which is very unique, when you have a diagnosis of obstructive sleep apnea, where does DICE and then the ENT evaluation come in? Is it more first line, or do you do what we do here, which is you're going to try CPAP, and then, if you fail, and part of that discussion obviously is the severity of sleep apnea, how frequently your airway is closing off per hour. And I'm sure hypoxic burden falls into that. So how low your oxygen levels are and for how long you're spending time with low oxygen levels.
That's an excellent question, Alison. So every potential sleep apnea patient that gets referred into our ENT sleep service gets an ENT evaluation, either with myself or a member of my team.
So right off the bat, you're doing a very detailed physical exam.
Absolutely. So every snoring and sleep apnea patient that sits in front of us for the very first time gets a flexible nasal endoscopy to evaluate for any anatomical risk factors like a deviated septum, polyps, grade 4 tonsils. So those potential anatomical risk factors are identified during the first clinic consultation. Once we've reached a diagnosis of sleep apnea with a sleep study, we have sleep physiologists that work within the governance framework of ENT at University College London hospitals who can then initiate CPAP therapy. When I would start considering something like a drug-induced sleep endoscopy is if the patient has already tried CPAP or a customized mandibular advancement device and is unable to tolerate those first-line interventions. Within University College London hospitals, that is the sort of rationale and process that we would take. In some situations where we are highly suspicious of something like a primary epiglottic collapse, where patients already report feeling suffocated, just with one night of CPAP therapy, we may bring the drug-induced sleep endoscopy evaluation much sooner in the pathway, just to make sure that they don't fall in that 15% of so patients with primary epiglottic collapse.
Fascinating. So we are really underutilizing DICE potentially. What are the advantages of incorporating this early flexible endoscopy and then maybe even using the DICE more aggressively?
Yes. So I think there has been a lot of work around the psychology of CPAP compliance, and there is a critical time window of about the first 7 to 10 days of CPAP use. If the patient has a good experience during that initial time frame, their likelihood of being compliant with CPAP therapy increases quite significantly long term. So if you imagine the way that CPAP works, as you know, it's essentially like a pneumatic splint. It's pumping pressurized air into their nose and throats. So if you imagine if the patient comes to you for the first time with a deviated septum, an obstructive deviated septum or grade 4 tonsils, right? And you place a pressurized mask on them, you're going to need a lot more pressure to be able to splint their upper airway. However, in our case, these anatomical points get addressed quite early on. So by the time they're on the waiting list to receive CPAP therapy, their anatomy would have been much more optimized to have a much more comfortable time, hopefully improving their compliance long term.
I just had a wonderful conversation with Dr. Audrey Yoon, orthodontist.
Yes.
And are you utilizing tools or relationships with orthodontics to do MARPE as a part of your algorithm?
So, yes, we've been thinking about this for a while, but the limiting factor is the available orthodontists with these types of skill sets within London in particular. So there are new orthodontists and maxillofacial surgeons who are upskilling to train in the use of MARPE and these sort of palatal expansion interventions, but they're just emerging at this point in time. So the limiting factor is accessing this particular skill set. But I'm very familiar with Audrey Yoon's work, which is excellent. But yes, we are trying to sort of tap into those sort of frameworks and skill sets earlier on, but we just need the skills to be developed at present amongst our orthodontic colleagues and maxillofacial surgeons.
I want to pivot a little bit
Sure.
and kind of talk a little bit more about your advocacy work. So
Please.
we were sharing that in the United States, what I do is I have collaborated with the American Academy of Sleep Medicine. It's one of my passions to volunteer for them. And myself and a bunch of my sleep friends, I call them now because we're so close, we go down to Capitol Hill, so we go to Washington, D.C. We may either speak with someone who's a representative for a congressperson, or we may actually, on occasion, get to meet someone who is the actual representative or congressperson and be able to discuss sleep health issues. How does it work in the UK? What is that like? Because you posted something that sounded so cool.
Yes, so I think one thing leads to another. So in December 2024, myself and my team performed the first Genio bilateral hypoglossal nerve implant in the UK. So quite early on, December 2024, when we performed this procedure, we gained a lot of mainstream media attention, as you've highlighted. So I think they did a media impact assessment of that time frame, and it was in the region of about 2.54 billion potential viewers across the different platforms of the BBC, Sky News, The Times, The Guardian. And so that gave us a certain platform to be able to then leverage to advocate further for our patients, for our sleep health, sleep apnea, snoring patients, ENT patients. And following on from that particular work, we developed relationships with different media outlets. So The Guardian, The Independent, and we were able to basically sort of shape the narrative in a way for the benefit of our patients to raise awareness within this realm. Eventually, the news reached the government within the UK, and we were invited to share more about our work at number 10 Downing Street with the Deputy Prime Minister, about the work that we were doing in ENT and snoring and sleep apnea. And so we were very lucky and fortunate to be given this particular platform to be able to raise awareness. But essentially one thing led to another, Alison, and we're just continuing to chip away at the 85% of patients in the UK that are still undiagnosed.
Talk to me about the Asian community in the UK. What do we need to know? You know, my mom is Korean, and I know you were sharing with me you're from Malaysia.
Correct.
So much of the Asian population, the sleep apnea issues are really craniofacial, smaller airway, just how our genetics have led us to be built.
Right.
And obviously you do ENT. Correct. So this means I'm sure that you probably have a fair number of these Asian patients. What are the issues that, in terms of sleep health, affecting the Asian community that you've seen?
So you've highlighted it perfectly, Alison, that a lot of the Asian population, they have slightly more unfavorable craniofacial features, so slightly more backset mandibles, slightly more hypoplastic maxilla. And so these types of craniofacial features, they can predispose them. Not always the case. Sometimes there may be other elements at play as well in terms of their physiology, the way their muscular tone holds itself when they sleep at night. But being more mindful of the potential interventions required for the Asian population, specifically for their craniofacial anatomical phenotype, is quite important. And we're quite mindful of that in our ENT practice. When we see a patient of Asian heritage, we just start thinking about sort of anatomical interventions earlier on compared to patients coming from other forms of ethnicities.
What is the recognition of obstructive sleep apnea in the Asian community? I have told the story before, but I will share with you when I used to visit my Imo, my aunt in Korea. She was always falling asleep everywhere. And as I learned more about sleep, actually having graduated my sleep medicine fellowship was the last time I was in Seoul. Okay. I see here this was circa 2013, so I'm dating myself now. It's been a while since I've been there. They had a room built in her church, and you would see all of these older people snoring away and taking naps. And they'd be like, well, they get up early to go to church. I'm like, no, it's a room full of people with untreated sleep apnea. What is happening here? So I was just curious if that is just one observation that is an N of one, my perception, or is that a real barrier and issue?
I don't think it's specific to the Asian community in general. I think the awareness of the potential impact, the negative impact of sleep disorders, things like troublesome snoring is usually just downplayed or ignored within most communities. But I think the awareness that's been raised is in particularly the younger generation. So I've been experiencing more and more patients come through because they were brought in by their children. Particularly Gen Z, their sleep awareness is, I think, at an all-time high. So a lot of patients that come through have actually been brought in by their children, their younger siblings, to say, hey, you need to be taking your sleep health more seriously. And I don't think this is particularly affecting a specific community, for example, the Asian community. I think it's across the board, but that's changing. So I'm seeing a new wave of sleep awareness, not just because of mainstream media work that has been done, but also on-the-ground awareness of the incoming generation.
And I have to say, I've been seeing a lot of young Asians, premenopausal women, so young ladies, young men who are addressing their own sleep. Somehow, again, they're in that wheelhouse of actually caring about their sleep. So maybe this discussion, we need the older folks to get on board with it because the younger ones seem to be, grasping it.
Yes.
Probably the power of social media in part.
Correct.
There's good things and bad things about social media, but the level of education that people could get is sometimes not so bad, especially if they listen to reputable sources such as ourselves.
Thank you, Alison. But it's interesting to see how the awareness in one generation affects the other generations. And I think it can only be a good thing.
In your experience with what you've seen at your hospital, the care pathway for an Asian patient, do you think there's room for that to be changed? Meaning, should we be addressing, especially in thinner patients, maybe CPAP isn't the whole thing?
Absolutely.
Like, should we be thinking a little bit more aggressively about other types of anatomic interventions in that?
Absolutely. I think by the time they reach our ENT sleep surgery clinics, they really get offered a personalized plan for their specific pathology in terms of their source of obstructive sleep apnea. Is it anatomical? Is it physiological? Is it lifestyle, obesity related, alcohol related? So they get offered the full spectrum of treatment for their ENT snoring and sleep apnea issues. I think the challenge really is it's before that point. So recognizing that a slim Asian patient with unfavorable craniofacial features or anatomy, to raise awareness that these patients, although they're not obese, could still be at risk of developing obstructive sleep apnea is the main key here. So having that identification earlier on in the pathway in primary care, because at the moment, there's still this misconception that only overweight men get sleep apnea, right? Which we both know is not the case because of the factors that we just talked about with anatomy, with the craniofacial features, particularly within the Asian community. So having that identification earlier on would be helpful.
Amazing. Do you have any data in terms of outcomes in using your pathway, which is unique? I'm wondering if that compares differently to other systems that you have.
Yes. So I think, broadly speaking, the non-compliance rate with CPAP therapy across the board, something in the region of anything between 34% to sometimes as high as 80% of non-compliance. I would say that we're able to keep that non-compliance rate closer towards the lower limit, around 34% or so within our practice, in terms of how things are set up, in terms of our early ENT evaluation for our sleep apnea patients. We're able to maintain a non-compliance rate that's more in keeping with the published figures that are closer towards the lower limit. So that's what we have.
I think that's excellent because that's been one of my sources of frustration is I know I'm talking to, let's say, young patients, pretty bad sleep apnea, and I'm like, oh boy, and there are lots of chronic nasal congestion and everything. And oftentimes they may have seen ENT, but maybe they're not very sleep forward.
Absolutely.
And so then it becomes, well, I don't see too much there. Okay, just address, it's not that. So it makes me think that there's a role for more ENTs to get involved with sleep in the United States and maybe start to shift the care pathway, or at least have those discussions about, can we show any meaningful data points that point in the direction of just improving treatment in general. And that access, I think, would make patients feel more comfortable.
Absolutely. And it's exactly like you mentioned. A lot of the times, ENT surgeons do have the skill sets to address these types of pathology, nasal congestion, anatomical obstructive points in the nose, in the throat. But it's just having that awareness to be looking for these things in the context of sleep disorders, and how even something as potentially mild as a simple nasal congestion can impact their compliance with nasal CPAP therapy, for example, and the importance of really trying to optimize nasal airflow as much as possible, not necessarily to treat or address the sleep apnea, but to improve the compliance with the other forms of medical treatment options like CPAP therapy or mandibular advancement devices. So just having that awareness can be really helpful, particularly within the ENT community.
Speaking of surgical interventions, I would be remiss if we didn't talk about the fact, right? You mentioned DICE.
Yes.
Basically invented at your hospital.
Correct.
Using that as a tool. And now we have Inspire, we have Genio. There's another one. It's the LivaNova's Aura 6000 that just got FDA approval in the United States. But in speaking with my connections there, I know they're not planning to officially go for launch. They want to have a device, I believe, that's MRI compatible.
Right.
You've done all three, I presume?
So I've done Inspire and the Genio XOA.
Okay.
LivaNova is not yet available in the UK.
I'm going to be so interested in seeing what comes of that.
Yeah.
Talk to me about Inspire and Genio. Maybe you could quickly educate my listeners on the differences.
Of course.
And because this is unsponsored, this is unbiased, I'm not in the pocket of Inspire or in the pocket of Nick Soa, who makes Genio. I'm just curious about your experience with it, and where do you see one maybe fitting in for certain patients versus another?
That's a fantastic question, Alison. And I actually frequently get asked that particular question. And also we can talk about the role of DICE in the context of sleep surgical intervention.
Please.
But in essence, these types of nerve stimulatory devices for sleep apnea, they, in a way, are an advancement to our existing sleep surgical interventions. If you think about surgery for sleep apnea, as a surgeon, we're trying to operate on an area, on an anatomy of the body that is dynamic, that changes its form depending on the patient's state. So, as we know, sleep apnea is a state-dependent disorder. It only occurs in a specific state during sleep. When they are awake, they have absolutely no issues for the vast majority of them. So if you're trying to perform surgery on that particular anatomical region, you're almost trying to hit a moving target, correct? Because that deformation, the way that the obstructive pattern, anatomical pattern occurs, is specific to a particular state. So the first principle, sort of thought process as a surgeon is, how do you hit a moving target? How do you operate on a body part that deforms day and night? So historically, a lot of the operations that we used to perform for our patients prior to the hypoglossal nerve implants were reconstructive procedures to the palate, to the throat, ablative procedures to the tongue. The challenge with those types of interventions, and I still have to perform those types of operations for patients who don't meet the eligibility of the hypoglossal nerve implants, the challenge is balancing effectiveness and complication. So if I don't do enough of the reconstructive operation, it's not as effective. If I do too much sometimes or too aggressive, we can run into the realms of complications with pain, bleeding. Now, the nerve implant, the hypoglossal nerve implants, offered us a way of essentially titrating the surgical therapy to the patient's state, because you're able to switch the device on at night and off during the day. So you're able to titrate it to that specific state. So in terms of advancements, that's, in my mind, one of the reasons why it has been a step forward, is because you're able to titrate that surgical intervention to that specific state, which is sleep. And the second reason is that you're not ablating or disrupting the native anatomy of the patient. So we're not cutting into the tongue or the palate. It's pulsing the hypoglossal nerve, shifting the tongue out of the airway as required. So you're preserving the integrity of the anatomical structure. So pain, the complication rates are more favorable compared to some of the legacy operations that we used to do. Now, between Inspire and Genio, beyond the eligibility criteria, the paper eligibility criteria, which, in the United Kingdom, the patient needs to be at a body mass index of less than 35. Their AHI score needs to be between 15 to 65. They need to have at least tried CPAP and are failed or been intolerant of it, and then they can progress. But we're finding that there are actually nuances beyond the paper eligibility criteria that sort of shift the patient's preference towards one type of implant versus the other. MRI compatibility is a big one. So I know that now the recent iterations of Inspire, they've gained 3 Tesla compatibility, but the historical versions are only limited to up to 1.5 Teslas, whereas Genio, it's fully MRI compatible to up to 3 Teslas, even with their initial models. An interesting factor that patients choose Inspire versus Genio in my practice is actually facial hair. So if you have a lot of facial hair for aesthetic or religious reasons, where you're unable to attach the adhesive patch that is required with the Genio Nixoa device, then patients won't be able to use that. You won't be able to use the Genio Nixoa implant. And that has been, in my practice, one of the examples of how you identify these nuances once you've been in practice enough and you've seen enough of these patients come through that go beyond the sort of published eligibility criteria. Some patients, especially within the neurodivergent population, they have a lot of difficulty with sensory stimulus over their faces. And that's one of the reasons why they were non-compliant with CPAP in the first place, right? So sometimes even a little adhesive patch.
That would make me crazy. I'm just going to be honest.
There you go.
Like even thinking about this, I'm like, how do I sleep in that thing?
So there's a sticky patch that it's very lightweight, by the way. It's very light. It's barely perceptible in terms of its weight. However, you can imagine how some patients might struggle even with a little patch underneath their chin, whereas with Inspire, it's fully embedded. Why some of my patients would sort of pivot more towards the Genio device that goes beyond the paper eligibility criteria is the fact that with the Inspire device, the power source is implanted, it's embedded. So you need to have sort of a further operation every 10 years or so to replace the power source. Whereas with the Genio Nixoa device, the power source is external. So technically, although we don't really have long-term data at present, technically, you don't need to have a further operation to change the implantable component.
Though I did hear that there's some sort of a cap to the life of this device. And I don't know if they had to put that in, as
I think
like we just don't know.
Correct.
It's a brand new device.
Exactly. So nobody really knows because it hasn't been around for 10, 13 years for us to be able to predict or have any data to say how long these sort of silicone-encased ceramic chips would last, basically. But technically, from a power source perspective, you shouldn't need to replace it if the implant remains intact and doesn't disintegrate.
And similar outcomes, that's my impression.
Correct.
From, I know there's no head-to-head trial.
Yes,
so and again, I always explain, it's, they're not randomizing people and then looking. At least they're not doing it yet. It's just more what has been reported.
Yes, similar outcomes between the two. Similar outcomes between the two in terms of the response rates, the difficulty, the sort of refractory patients, the proportion of refractory patients that come through, quite similar between the two. But it would be interesting to see how the technology develops further, particularly because I know that within the pipeline, both companies are within their research and development trying to improve the implant's ability to titrate the stimulation depending on the patient's state more specifically within sleep.
Yes. Are there any key features to more quickly triage who might be refractory? I don't know that we know that answer.
That's a very good point. There have been some publications that have come through. So patients with a lot of supine obstructive sleep apnea may do less favorably. Patients with insomnia struggle because the ceiling that you hit is the arousal threshold, because they get woken up by even low levels of stimulation. Before you're able to optimize the settings, patients are already woken up at low amplitudes of stimulation. So I'm finding that in my experience, one of the ceilings that I'm hitting early on in patients who are refractory, not necessarily a physical reason, because the implant is not effectively shifting the anatomy, but it's more from an arousal threshold perspective. These patients are not able to sleep through the stimulations. So what we tend to do is we try to treat their insomnia in parallel to their sleep apnea. So we refer patients very early on to our sleep psychiatry colleagues who specialize in insomnia. Just to give you a little bit more flavor of our setup at University College London hospitals, we have 4 major hospitals within the trust that look after sleep disorders. So you have one hospital, which is the hospital that I'm based at the Royal National ENT, that deliver sleep surgical interventions. We deliver ENT evaluations. A lot of the patients come through to us for their first clinic appointments. We have our sleep dentists, which sit within that hospital as well. And then you have University College Hospital itself, where our respiratory physicians, pulmonologists sit that support us with central sleep apnea, any comorbid respiratory disorders with sleep apnea, they support us with that. We have the National Hospital for Neurology and Neurosurgery, where we have neurologists who specialize in neurological sleep disorders like narcolepsy, restless legs. And then finally, you have the Royal London Hospital for Integrative Medicine, where we have some excellent psychiatrists who specialize in insomnia. So we lean on each other's expertise quite early on, particularly in patients with comorbid insomnia and sleep apnea, where they almost need a parallel treatment for both sleep disorders. If not, you will be hitting a wall, essentially a ceiling, for treatments of both, of insomnia and sleep apnea.
That is a great point. And what he's referring to is COMISA.
Correct.
So check out Alex Sweetman's, I've talked to Alex Sweetman before, so check out that episode.
Yes.
We'll make sure that you're aware of it. So I've got 2 final questions.
Sure, please.
We're going to wrap up. You sit right at the intersection of ENT and sleep medicine. What does good collaboration look like when it's working well? And how often do you see this in the NHS?
I think good collaboration, particularly for our sleep disorder patients, is absolutely critical, Alison, because as we've already been talking about for the past 5 minutes or so, frequently patients have multiple sleep disorders. And a lot of times you need multiple specialists with different skill sets to treat those sleep disorders. So I think good collaboration looks like early communication, early referral, and early involvement from multiple specialties. And within University College London hospitals, we have a sleep multidisciplinary team meeting where we discuss complex refractory patients. We have sleep physicians, ENT sleep surgeons like myself, sleep dentists, sleep physiologists that sit in that meeting that can go through these more complex refractory patients. So
fantastic idea. Yeah. I feel like, we often practice a lot in silos in the United States.
This is a relatively new initiative that we've been sort of introducing in the last 12 to 18 months, but it's something that has really shifted the needle for our more complex refractory patients, because historically, in order for a patient to have their insomnia looked after, have their sleep apnea looked after, have their restless legs looked after, they need multiple appointments with multiple consultants or attendings through different clinic reviews. That process we've looked at this timeline, can sometimes take 3 to 4 years to complete.
Oh, that's crazy. Yeah. Meanwhile, your sleep has been disrupted.
Correct.
That entire
with
time.
Multiple sleep disorders, exactly.
Wow. Okay.
So if you're able to get all of us in a room together, or a virtual room, for example, you're able to have that expert opinion integrated quickly, and then the patients get their treatments much earlier on.
That's such a fantastic idea. Oh my goodness. When you imagine the future of sleep and airway care in London, let's say in a decade from now, what do you hope will be true that is absolutely not true today?
That's a very good question. I think our ability to specifically titrate treatment, surgical treatment for the upper airway in London or in the UK in general will become more granular, will become more nuanced. I think there's been a lot of research and development into other forms of neuromodulation, not just the hypoglossal nerve, but other types of nerves within the head and neck region. People were talking about things like the ansa cervicalis, and also the multimodality delivery of these treatment options, not necessarily as a siloed treatment. I think a lot of times, because of the availability and the cost associated with the hypoglossal nerve implants, it's almost seen as a final siloed treatment when everything else has failed, or patients have tried a range of different options. then they get this one final go.
Mm-hmm.
But the way I anticipate things developing in the next decade is that the hypoglossal nerve implants, or any other nerve implants for that matter, would just become an adjunct, particularly in the more severe complex sleep apnea patients that need multiple modality treatments to really improve or alleviate their disease burden. The inclusion of pharmacotherapy, so things like the AD109 drugs, could potentially be exciting as well when it becomes available in clinical practice. So a combination of these things, I think it's a very exciting time for us, Alison, in sleep medicine and sleep surgery. It's almost like you're right now at the convergence of awareness, mainstream media awareness, social media awareness, on-the-ground awareness from the newer generation. We have this new forms of therapies, pharmacologically, surgically. The GLP-1 receptor agonist, also a very exciting area, that's only going to grow. So we're almost, I wouldn't say almost, but we are realistically at almost like a renaissance period for sleep medicine and sleep surgery, and we're living it. So very hopeful. I think we'll be able to do a lot of good for our patients within the next decade or so. And because of the complexity of the disease, that makes looking after these patients just that much more satisfying and exciting, because I get to work with people like yourself with different specialties, because all our skill sets are required to really move the needle for these complex, multifactorial patients.
I'm going to be looking forward to hopefully being able to better phenotype. Like maybe we can get to, I'm seeing this constellation, this pattern, this particular patient. This is going to be this is the door number one for you,
yes.
Right? Especially for those that we know have a lot of the nasal congestion issues and everything.
Yes.
Ryan, thank you so much.
It's a pleasure, Alison.
For taking us inside the UK system and for the work that you're doing as both a sleep health advocate and a surgeon. If you enjoyed this conversation, this is just one stop on the Sleep is My Waking Passion Meets London series as we take the podcast on the road to understand sleep care around the world. That's a hint, hint, wink, wink. Going to be returning to South Korea. If you learned something, please follow the show, leave a quick rating and review, and send this episode to someone who needs to hear it. And if you want more conversations like this, you know where to find me. Go to AskTheSleepMD.com or check out my YouTube channel.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.